Thanks, guys. Yeah, so for those that don't know me, yeah, I'm David. For those that do know me, I'm very sorry. Now, I have to be honest, I've lost track of what I'm actually supposed to talk about today. The topic's changed more often than my underwear this year. So what am I talking about? What did you want at the end of the day?
You are for care of tonsillectomy, adenoids,
Tonsils,
T's and
adenoids.
A's,
Yeah.
patients, and discussion about sleep apnea and
Okay.
sleep obstruction.
All right, so you don't want grommets? Okay, cool. All right, so tonsils and adenoids. Tonsils and adenoids, we're going to talk about it in the kids' point of view because that's mostly what I do. So from a tonsil and adenoid point of view, I want to go through why we do it and how we do it and what they're like afterwards, just so you sort of get a before, during and after experience, okay? So the main reason that I see children with regards to making the decision to take tonsils and adenoids out is because of airway obstruction. Now, airway obstruction is something that has gone in and out of favour when you go through history over time. If you go back about 100 years and look at ENT books that were written back then, which is a sad reflection on my life, the fact that I've done this, the number one reason tonsils were taken out back in the 1910s, the 1920s was snoring, okay? What happened over time is that tonsillectomy as an operation got way overdone. There's actually a hospital in New York that was the tonsillectomy hospital. It's where you went just purely to get your tonsils out. And when you go back and look at the history of that, there was a study where they basically got a group of kids, I think it was like 100 kids, whatever it was, and they went and saw an ENT doctor and said, look, how many of these kids need their tonsils out? And it was about 80%, okay, was the decision. And then so they had 20 left over. So then they took that 20 to another ENT surgeon, said, look, how many of these kids need their tonsils out? And it was about 80%. And then so they had, 4 or 5 left over. So they looked at a third ENT surgeon, who these kids need their tonsils out, was pretty much the rest of them. So it was heavily overdone. And one of the reasons it was done was basically because if your brother or sister needed it, whilst we're there, we'll do it as well, okay? So the pendulum swung way, way, way into ridiculous territory. And then people sort of woke up themselves and said, well, look, what are we actually fixing here? And then it swung back to basically not doing it at all. So there's a period of history where the main reason they would take them out was because you had to have a shocking amount of tonsillitis. And even then they'd say, oh, maybe if you get it one more time, then we'll do it. And then when you got it, it'd be like, oh, maybe another time just to be sure. So it was really hard to get your tonsils out for a while. What happened in around about the 1990s was there was an ENT surgeon that went to one of the local schools. There was in the USA. And he was interested in airway and breathing and sleep. And he said, look, can you give me the bottom 10% of your kids in terms of their school performance? And those 10% of kids, I want to send a letter to the parents. And the letter to the parent was really simple. Does your kid snore and stop breathing at night? Okay? If the answer to that letter was yes, they do, they were then offered the opportunity to be assessed and then offered surgery if that was appropriate to address any airway obstruction they had because of their tonsils and adenoids. When they went through that process and they looked at the outcomes, those kids all did better at school. Every single one of them, okay? And that was sort of the turning point, again, of going, well, actually, maybe infection's not so relevant. Maybe if someone can't breathe properly, that's something that's important for us to look at and intervene. And from that, that's really just sort of, the growth curve's been exponential with respect to recognising that tonsillitis in kids is completely irrelevant when it comes to deciding on taking tonsils and adenoids out, okay? And if you look at sort of the numbers across the board, roughly around 80% of kids under the age of 4 that are having their tonsils out is because of airway obstruction, okay? And around about 25% is because of tonsillitis. Now, for those of you that are mathematically astute, you'd realise that 80 plus 25 is more than 100%. That's because some kids do actually have both, okay? It's not that ENTs are mathematically challenged. It's just that some kids do actually have both, all right? So that's kids under the age of 4. If we go from 4 to the age of 8, those numbers change, roughly speaking, to around about 75 versus 30%. So still a lot of airway obstruction versus tonsillitis. And when we go into the teenage groups, then the numbers sort of switch again to around about 60 and 40, 45-ish, because you get more tonsillitis. But even then, airway obstruction is still trumping them, okay? So what's this whole thing about airway obstruction? What is it? The specific terminology, we get sort of terminology mixed up and it gets a little haywire. So everyone talks about obstructive sleep apnea, okay? Now, Obstructive sleep apnea is borrowed from adult respiratory medicine, and a lot of the mistakes we made was basically just saying, well, kids are small adults, and they're not. The whole story is completely different. But we took it from adults and said, well, adults either snore or they snore and have sleep apnea. And if they snore, that's a social problem. If they have sleep apnea, that's a medical problem. So we did that in kids. We said, well, if they snore and stop breathing, and they've got problems in terms of how they're going during the day, well, yep, we need to fix those kids. The problem we had is we had a group of kids where they were snoring and they were struggling to breathe at night, but they weren't actually stopping. They were still managing to get a breath through. But they're having all the problems during the day that these kids with sleep apnea were having. And people started dabbling a bit and started treating them, and those kids started getting better. So we had to create a new term, so we called it upper airways resistance syndrome, because unless it's got a name, you can't fix it. Okay. So that was that group. So we sort of had sleep apnea and upper airways resistance syndrome, and that sort of persisted probably through to around about 2000, 2001-ish, and then we started just looking at kids that were snoring, and we were looking at kids that were what we call habitually snoring. So they were children that were snoring 4 nights of the week or more. Okay. The thing about snoring is a noise that's made because there is a blockage to the breathing. Okay. When these children snore 4 nights a week or more, and we look at them, they have an increased chance of having daytime problems. I'm going through the daytime problems for you just so you sort of know what it's all about. But then we started fixing them, and they started getting better. Okay. And then around about 5 years ago, we started looking at kids that weren't even snoring, but they were mouth breathing. Okay. Mouth breathing in children 80% of the time is because there's some form of obstruction to breathing through the nose. So they're forced to breathe through their mouth as a result. The complex physiology, which I'm not going to bore you with, when you breathe through your mouth, your oxygen saturations drop around 2 to 3%. Okay? It's just one of those physiology things. Don't worry about the fine print. In children that mouth breathe, they have increased risk of daytime problems too. And when we fix them, they also do better. Okay? And the big paper that came out with that was from 2012 from Einstein University, or whatever it's called, a lady called Karen Bonnock, where they looked at 11,000 children over the course of the first 7 years of their life. And they did behavioural and psychometric and all sorts of outcome measures at the age of 4 and the age of 7, and then looked back in their history to see if they had any presence of what we now call sleep disordered breathing. And that's the key term. Sleep disordered breathing is the spectrum. It starts at mouth breathing, it goes to snoring, it goes to upper airways resistance, and it goes to sleep apnea. That's the spectrum. Okay? And what they looked at is they looked at children specifically to see what were the outcomes for children if they demonstrated sleep disordered breathing consistently at 2 6-month assessments. And the assessments are really easy. They asked the parents, does your kid snore, mouth breathe, or stop breathing at night? Okay? And if the answer was yes to any one of those 3, 2 consecutive time points, which was roughly 6 months apart, then that child was notionally said that child has sleep disordered breathing, and then they looked at their outcomes. Okay? And they control, when you have 11,000 kids, you can control for things like the economics of the parents and crowded houses and smoking and all sorts of things that can muddy the waters in terms of what you're looking at, and narrow it down really just to what's going on with the breathing, the sleep, and then the outcomes. So during the day, they looked at things such as concentration, behaviour, how well the children are related to their peers, what we call emotional lability, so that's the kids that cry at the drop of a hat over nothing, okay, the fragile children, and a whole heap of things. In short, what they found is any child that demonstrated sleep disordered breathing at any stage for the first 7 years of their life, depending on which outcome measure you're looking at, there was a 20 to 100% increased chance that they would have some form of behavioural schooling problem as a consequence of sleep disordered breathing. Okay? Then they extended that and they said, well, what about kids that get better by themselves, kids that outgrow it? So they looked at children that had some form of sleep disordered breathing before the age of 4 that had resolved by the age of 7. Okay? Those children, even though they had got better, 40 to 50% increased chance of some form of behavioural problem at the age of 7, which they could tie back to the breathing problem. Okay? So they didn't grow out of it, they grew into a problem. Then they looked at kids under the age of 18 months. So these are kids that had it at the age of 18 months, okay, or less, and it had gone by the time they were 4, and they looked at the age of 7. Those kids were also way off the scale in terms of what was going on. And we've done studies where we look at children and we do MRI scans and what's called functional MRI scans, and we can look at their brain. Their brains don't function the same way if they have sleep disordered breathing. Parts of the brain that control their behaviour and so forth, their frontal lobes, are different. Parts of the brain that control their memory are different. These children struggle during the day. So the things that we look for in these children as a sort of benchmark of things, we ask about what's going on during the night. So we want to know about snoring and mouth breathing, sleep apnea. We want to know, do they grind their teeth? Teeth grinding's been put down to stress, and that's true. But in children, there's very few children at the age of 4, 5, 6 or 7 that are worried about their girlfriend finding out they're cheating on them and they're about to lose their job and how they're going to pay their electricity bill. Okay? Alright? These children are stressed, but they're physiologically stressed. They're physiologically stressed because of the low oxygen levels. Okay? Now, I told you that the oxygen levels drop around about 2 to 3% when they're mouth breathing. In adults, we sort of say, look, if you sort of drop below 90%, that's when you're starting to run into pathological territory. For kids, when they hit about 96, 97%, that can be their tipping point. So if you do the math of 2, 3% on mouth breathing, those kids are sitting on the cliff ready to be pushed off the edge straight up. So we look at teeth grinding, and teeth grinding is a physiological stress response to low oxygen levels. Okay? We want to know about sleepwalking and sleep talking and night terrors. Okay? Night terrors is actually significantly underestimated in terms of its relationship to sleep disordered breathing, but you look at the studies, it's way off the scale. Okay? So night terrors. So we've got sort of the nighttime things. We want to look at bedwetting. Okay? And it's bedwetting beyond a normal age, and everyone argues what a normal age is, 6, 7, 8, whatever. What we know is that when we go and intervene with kids that have got bedwetting tied in with sleep disordered breathing, about 40% of them will stop bedwetting. Okay? There and then. Done. So what it means is that 40%, it was being triggered purely and simply because of their breathing problems at night. For children that do things like teeth grind and sleepwalk and sleep talk and night terrors, 80% of them will stop in their tracks there and then once we get their breathing and sleep sorted. Okay? We want to know about the kids that toss and turn at night. Okay? The restless sleepers, the ones that sweat at night. When you get anxious, you sweat. Okay? Your sympathetic nervous system goes up, you start to sweat. That's what happens to these children when they're asleep. Okay? When they're asleep, their oxygen levels go down, their sympathetic nervous system goes up. These children have measurable elevation in their blood pressure. They have measurable changes around their heart with what's called pulmonary hypertension. They get to the point they can get right heart failure. Okay? And they'll sweat at night simply because of the adrenaline surges they're getting because of the stress of breathing. So there's some clues for nighttime. Then we want to know, what are they like when they wake up in the morning? Are they waking up tired or refreshed? Okay? It's not the quantity of sleep, it's the quality of sleep. 4 good hours is better than 12 bad hours. Okay? So these children that go to bed and sleep, and then the parents have to basically push them out of bed at 7 in the morning, having slept for 12 hours, and say, well, they've had a good sleep. Not if they're waking up tired, they're not. Okay? So are they tired or refreshed in the morning? Okay? Do they wake up with dark circles under their eyes? Do they wake up with headaches? Do they wake up with a dry mouth because they're breathing through their mouth through the night? Do they have bad breath, again, for the mouth breathing? And then what are they like during the day? Do they have any problems with their education? Are they struggling at school? Do they have any problems with their emotions? Do they have any problems with their behaviour, their concentration, okay? And just their energy levels? We know children that have sleep disordered breathing, if we get them to go and do a fitness test, okay, they will do poorly compared to someone that doesn't have sleep disordered breathing, just as that outcome measure alone. So their physical capacity is reduced. So it has a major sweeping effect on all sorts of things in that regard. And if we dig right underneath the surface and we go body system by body system, we can find aberrations in every single body system when it comes to sleep disordered breathing. Okay? So if we look at skin, for example, and this applies to adults too, if you have problems with your sleep, the laxity of your skin increases because you get all these enzymatic changes, so you get wrinkles quicker. Right? So a good night's sleep is good for your complexion. The same with acne. Okay? If you look at the eyes, for example, in adults, it's indicated that if a person presents with glaucoma, they need to be screened for sleep apnea, because sleep apnea is a major risk factor for development of glaucoma. Okay? If we look at the eyes in children, one of the things we can do is that you can have pictures taken at the back of the eye, and that looks at the little nerve fibres. Okay? And when we do that in adults, but also actually now when we do that in kids, if they've had it long enough, we can actually see changes where those nerve fibres are dying off because of the low oxygen levels. Okay, it's that significant. So I'd mentioned the phrase there deliberately, sort of as a segue to if they've had it long enough. Okay, what we've known sort of independently is that there's two factors at play that determine outcomes in terms of the chance of having an impact. The first one is the younger you are when it first starts, the worse off you are likely to be because the more susceptible and vulnerable you are to the low oxygen levels. The second thing is duration. So the longer you've had it, the worse the chances, or the higher the chances are you're going to have a worse outcome. Okay, and it's just come out of Canada, out of Vancouver about 2 months ago, where they looked at both at the same time, and they're synergistic. You got starting young and having it for a while, you're even worse again. Okay, so it all adds up to badness, and that's not good. So that's sort of your prelude to the before bit, sort of just to get a big picture of what's going on. And sometimes there's overlap with things like hay fever and allergy, because you get a blocked nose from that allergy, and it's got nothing to do with your tonsils and adenoids, for example. Okay, it's just purely hay fever, allergy, blocking your nose, mouth breathing, and the problems that come from that. And that's why you'll see us would do turbinate reductions in kids to just get them unblocked. It doesn't cure allergies, but it gets them breathing again. So when they come in and they see us, obviously by referral, someone's picked up the fact that this kid can't breathe properly. We just do the simple stuff. We look in their ears, okay, because there's 20% of kids with this problem will have some form of problem with their ears that is not causing major ear infections, just with all the blockage, they're getting fluid build up in their ears that's affecting their hearing, for example. So we check their ears. Look inside their nose. Some children we have to put a scope in, most of them we don't. And we're just looking for simple things. We're looking, what is the nature of the nose? Is there changes of allergy? Have they got a deviated septum? The nasal passage is nice and clear. We look at the back of the nose and you can see big adenoids, or do you have to put the telescope in to check? And you look inside their mouth. You look inside their mouth and you're looking at tonsils. Now, when it comes to tonsils, in terms of looking at them, what we're looking at is how much space do the tonsils occupy relative to the space that's available, okay? Because small tonsils in a small space can cause more problems than big tonsils in a big space. Because the thing that's relevant is the functional space, which is basically total space, less tonsils is the functional space, okay? That's the bit you've got to work with and play with. So when we have a look in terms of trying to gauge things, we break them up into quarters. So if we have a look inside the available space compared to the tonsils, up to quarter of the space occupied is what we call grade 1. And most of the time, grade 1 tonsils don't cause any airway problems, okay? Grade 2 is beyond that up to 50%, and that's very hit and miss. Most of the time they don't, but there's a number where you do get problems there. Grade 3, again, is beyond that up to 75%, and that's when you get into territory where it's far more likely to be causing problems, and grade 4 is 75% and beyond. And sometimes we have what we call kissing tonsils. We look inside, the tonsils are basically just touching each other, okay? And the parents will go, but they don't get tonsillitis. That's just fine, because that sets me up and said, well, thank goodness, because imagine, what they'd be like if they had tonsillitis on top of this, and then you can just see them change their perspective where they're going, oh, they're not having tonsillitis, I'm not having them out, they go, oh yeah. It's just, their cognitive shift just goes, so we better get this out before the tonsillitis starts, and they go, yeah, we better. Alright, so that's sort of roughly just the assessment side of things. Okay. Sometimes, like I said, we use telescopes to have a look, and most of the time, we don't have to. So that's just the basic assessment. But there's little elements on top of the assessment. One of the big ones is jaw, teeth, and orthodontics, because there's a complex relationship that nobody understands, and I get sick of the arguments because the arguments don't matter. But there seems to be some relationship between having a breathing problem and the way the jaw's develop, such that the bottom jaw is short and the top jaw is narrow, right? So those two things limit the space that's available. So the space you've got to play with is automatically less, okay? And becomes, if it's all related, it becomes a bit of a vicious circle, because you get the breathing problem, which leads to the short jaw, and the narrow jaw, which limits the space, which means that the tissue, soft tissue part of it, compromises that space more, and you end up with this problem basically with the analogy I use as the room, okay? So in this room, if we wanted to make more space out of this room, there's two ways of doing it, broadly speaking. We empty everybody out and we leave the walls as they are, okay? Or we shift the walls, okay? The ENT bit is shifting the room out. The orthodontic bit is shifting the walls out, making the space bigger, and the ENT is making the most of the space that's available, okay? So that's sort of, part of the mix. Sometimes I'll see kids and I'll look at them and I go, well, look, you're going to get the tonsils and adenoids out, but this isn't going to fix the problem. It's a step in the right direction. You need to go off and see the dentist and orthodontist, and they will assess a child for all sorts of what's called expansion. They can expand the jaws out, they can train the front jaw to come forwards to make more room over time, okay? So it's a team approach in that regard. So that's sort of your broad assessment. So that's sort of the before bit. Now, when they turn up on the day, as many of you see, they turn up absolutely ecstatic to be here. There's no place they'd rather be. They go into that room down there, all nice and peaceful and quiet, totally excited about the experience. No resistance whatsoever. The parents are totally on board, completely happy about the experience. We put them off to sleep and have the wriggle and so forth, and then for some reason the mums cry. I don't know. I don't know what the anaesthetist says to the mum. They've really got to work on their pickle strips. When they're asleep, this is just talk tonsils and adenoids, all right? We open the mouth, okay? So we've got a gag that holds the mouth open, for those of you who haven't seen it. For those of you who have, I know it's redundant, but we've got to share. Give away all our secrets. We open the mouth. There is a multitude of ways of taking out tonsils and adenoids, okay? And to be honest, generically speaking, the technique does not matter, okay? What matters is the outcomes you get in the hands of the person that uses that technique, okay? So what's good in my hands will be terrible in someone else's, and vice versa. So it's not that there's a right way and a wrong way, but there are a few probably general principles just to be aware of, just to sort of weigh up what's going on. The first thing is when it comes to adenoids sit behind the nose, behind the palate, okay? The traditional standard way of getting adenoids out that's been around for many, many years is to get what's called a curette, which is just a scrape thing, all right, very technical, and we put it at the back of the throat and we scratch the back of the throat to get the adenoids out. When you do that, you cannot see what you're doing, okay? When they've done the studies where they sort of scrape it out and then someone puts a telescope in and has a look, what that has shown is that in about 70% of the time, you will leave some adenoid tissue behind, okay? And more so, if you look at overall numbers, probably around about a quarter of the time, you leave so much behind that the kid's actually still blocked, okay? So, and this has been known for like 10, 20 years, and the advent of other technology and so forth meant that we can actually get in there. So people started doing it with telescopes inside the nose and shavers, so the shavers that you might have seen in orthopedics or the ENT shavers, and putting it either in through the nose or you can put it through the mouth with an angle and shaving the adenoids down under vision, okay? The problem with that is it bleeds like crazy, and as soon as it starts bleeding in that space, it gets very hard to see what's going on. What I do, it's just everyone's different, is I use diathermy, okay? So I actually look inside, I lift the palate up, so I put something through the nose, put it around the palate to lift it up, put a mirror inside, and then working off a mirror backwards, melt the adenoids out the way we quarter it, okay? And they get a bit of sore throat and bad breath and temperatures and a snotty nose from that, more so than if you'd scrape them out. But you can see what you're doing, and you know the rationale behind that is you've got a better chance of getting the adenoids out. There's no 100% on anything, okay? There's no defining line between the adenoids start and stop, and you do have to stop at some point because otherwise you start getting onto the cervical spine, and that's sort of not where you want to be. So from getting an adenoid point of view out, I do it under vision. The nice thing about that sort of technique is that for kids that have had cleft palates, is you can actually go through the nose rather than through the mouth with a telescope onto the adenoids and just melt some of it away but not all of it away, because when you've had a cleft palate kid, the worry is that you'll take the adenoids out and then they'll have stuff come up through the back of their nose. So their plastic surgeons and so forth would have told them absolutely adamantly never ever let anyone take the adenoids out, and that's actually really good advice based on the standard technique. You've got other ways around it. It's just a matter of just convincing the parents, and usually ends up with a conversation with their plastic surgeon, just so the plastic surgeon can get their head around it, and so forth, and then they give their blessing and off we go. So they're sort of the special tricky ones. So that's adenoids, okay? Tonsils, again, a heap of ways of taking them out. You can take them out with what's called cold steel, which is basically just a knife and a scraper. You can take them out with diathermy, and that can be bipolar or monopolar diathermy. You can do it with laser, which is terrible. Don't anyone ever come near you with a laser in your throat, unless it's for cancer, because otherwise it's just torture for no great benefit. And there's coblation as well, for example. There's all sorts of other plasma ones. There's a multitude of ways. And some people are just adamant that their way is the best way, and it is in their hands. Okay? And that's all that matters, you know. People sort of focus on two things when it comes to taking tonsils out. They look at bleeding and pain. Okay? There is no surgical technique that obviates or gets around the fact that they get sore afterwards. It just doesn't happen. They will get the pain, it's just a matter of when it hits. Different techniques related to when the pain sort of sets in and so forth. And the big reason they get pain that's out of control is because of the parents. Okay, the parents do not keep up with the pain relief schedule. The kid starts refusing, and the parents go, "Oh, it's all too hard." They call me and I say, "Right, you need to go to suppositories," and they're like, "I'll try again." And it's amazing. Like, it's such a quick fix. All of a sudden, the parents seem far more determined when they understand the alternative. But you know, the crucial thing is just keeping up with the pain relief. Okay. So from a pain point of view, they all get sore. They've all just got to deal with it, short term for the long term, and that's the end of the story there. When it comes to bleeding, again, there's no magical technique that's better than another at the end of the day. And it depends what you call bleeding. Bleeding can be spitting out a drop of blood. Bleeding can be pouring out blood and putting you back into hospital, needing an operation and blood transfusions and all sorts of crazy stuff. Okay. So there's a whole spectrum of bleeding. The bleeding that's relevant to me is bleeding that puts them back into hospital, and then secondarily puts them back into theatre to stop the bleeding. Okay, and that's not very many, regardless of the technique. Okay, sort of benchmark standard is about 4%. If you've got a 4% return to theatre rate, that's pretty much international benchmark standard in terms of what you can expect. And if you're sort of going over that on a consistent basis, well, something's going wrong, and you just need to reappraise what you're doing. So if they spit out, and I tell them, look, a teaspoon, tablespoon of blood here and there is pretty normal. If it gets to half a cup of blood, that's time to come to hospital, get things checked over. Most of the time it'll stop by itself. These days we've got tranexamic acid, which is a procoagulant, so that actually sorts a lot of the bleeding problems out and saves us going back to theatre. But if it is a return to theatre, that is more of a drama. Okay. When it comes to doing your ENT exams and your anaesthetic exams, okay, to be a specialist, tonsil bleeding is pretty much every second or third year an exam question, because it's a good exam question. In terms of you have to know what to do, because the anaesthetic's different, the care's different, everything's different. It's an airway problem simply because you've got bleeding in the throat, okay, and then you're sort of trying to intubate and you've got blood everywhere. You've got to know how to deal with that. It's a breathing problem, again for the same reason. It's a circulation problem because they're bleeding, so they can become hemodynamically compromised, and so on and so forth. So bleeding tonsils is not fun. You probably won't have to deal with them too much here because they'll all end up across the road because the ambulance will take them there rather than here. But I'll tell you about it, just so you know. So having put the children through all of that, what are the outcomes? The outcomes are that for 80% of children that have sleep disorder breathing, we take their tonsils and adenoids out, that's all they need done. They don't need anything else done in terms of allergies, they don't need anything else done in terms of jaw and orthodontics. Those 20% of kids where it doesn't sort them out is because something else is going on. And probably the most common thing I see missed is allergy problems, or there was an allergy problem but that comes later down the track, okay? So they relapse. So that would be that. Adenoids not being removed comprehensively or adenoids returning again would be one of the other reasons for relapse, okay? Having jaw and orthodontic problems there, and then probably the other one, which is sort of fine print stuff, is having tongue-based problems. So some of these kids, we sort of clear up through here, we clear up through here, but they have a problem down there, okay? Fortunately, they're few and far between, and when I see those ones, I send them off for sleep studies, hoping that they'll have a normal sleep study so I don't have to touch them. Because taking out tongue-based stuff's never fun in adults, let alone in kids. The major concern you've got is with bleeding coming from the back of the throat, because it's very hard to stop. It's a return to theatre. I've only had to do it one, and it is what it is. But you know, it's not a fun experience. So sort of you want to weigh up the risks. So that's kind of tonsils and adenoids in the context of snoring and sleep. Now taking them out for tonsillitis, just to round that off, everyone has a rule of thumb. My rule of thumb is 6 in a year. This is the cases that need antibiotics, okay? So 6 in a year, or 8 spread over 2 years, or 9 spread over 3 years, which means basically getting sick every 2, 3 or 4 months. Probably go, yeah, if you had enough's enough, okay? So that's sort of a tonsillitis situation. So, I think I've kept the time. Did I do all right? You said give half an hour. I've done 37 minutes. All right. So I think I did okay. Are there any questions? We're all good?
Yeah. The symptoms that we all said, what about if you didn't pay attention when they were small and they teenage years?
Yeah. So we've got the studies that show that. So there was that study I talked about, which showed that children that had it early on, by the age of 7, they had problems with their concentration, their behaviour, their emotions, the way they dealt with other kids.